going to talk to us about lipids for the next 30 minutes. Dr. Rapp.
He's going to use that one.
It's a pleasure to be back in Little Rock, and I know that I will be timed. So, the talk that I'm giving for Dr. Bowles' request, supplements, evidence of benefit, or widespread belief, which I think epitomizes our visions. So I'm first going to talk about red yeast rice, and I may need some help with the pronunciation for the Chinese version of this. So red yeast rice basically is from the fermentation process with yeast, and that produces renascins, of which there are a plethora of, and they're fungal metabolites. And renascin K has similar structure to lovastatin. Lovastatin 20 milligrams is a low-intensity statin. It binds weakly, but nonetheless it binds with HMG-CoA reductase, which I'm sure you all know is the rate-limiting step for cholesterol biosynthesis. In terms of meta-analysis, which I'm always leery about, because if there's one large study, it'll basically override everything else. But the LDL cholesterol drop is between 14.7 and a little less than 50%, and that's the reference from Grant Journal Clinical Lipid Research. But a more recent paper by Cicero and JACC in Symposium and Review, it's about a 15 to 25% reduction in LDL. Triglycerides drop between 15 and 46%, which is pretty substantial for a statin. I'm not sure I believe that. HDL will increase by 17%. So basically, red yeast rice is pretty much a low to a moderately intense statin. A low-intensity statin lowers LDL by less than 30%, and a moderate-intensity statin lowers LDL between 30 and 49%. Pravastatin 40, Simba 10, and lovastatin 20. It did have anti-inflammatory effects in one paper. It dropped by 50%, which to me is very, very substantial. The hsCRP drop that you see with statins is about 10 or 15%. Red yeast rice can give some LFT elevations, although I am very cynical of LFT elevations because they come and go, and by the time you think about what it causes, they're gone. So, in fact, the National Liver Association doesn't even recommend checking GOT or GPT in patients on statins. There is a national reporting system of adverse effects, and that shows the odds ratio for rhabdomyolysis, which is a real effect with red yeast rice, and myopathy or myopathic brains. The odds ratio is about 8.4, which is about 8 times the risk if you did not have this. Liver enzymes about 13.7. Again, I think that that's overplayed. I think we see liver enzymes come and go, and the Brits for the longest time have said, don't even bother. By the time you check again, it'll be finished. What was the safe renascin level, renascin K level? Really wasn't known in the Cicero paper that anything between 3 milligrams and 10 milligrams of renascin K is minimal. Now, it's important to point out that when I talk about red yeast rice, or if I talk about supplements, there are very few studies with supplements where the target population are patients with ASCVD. So we're not going to see really WAPM, SHAPM, cardiovascular benefit. Red yeast rice, however, does have a trial. It's the Chinese coronary secondary prevention trial. It's about 4.5 years. It's about 4,800 patients. And by definition, secondary prevention trial means these patients all had prior MI. Now, typically we use a dose of 1,200 to 2,400, but the Chinese had their own version, and I'll leave it to my good colleague, Dr. Bao, to pronounce the word right before purified, because I sure can't. And that was a 300 milligram, almost purified extract that we used in the trial. The results, the primary endpoint was all-cause mortality, reduced by about 30%, cardiovascular death reduced by 70%, and non-fatal MI was reduced by about 60%. Patients tolerated the red yeast rice. There were no major problems with transaminases, mild CKAs, which can come and go. They were all similar to placebo. There is a primary prevention trial. It was published in Journal of Clinical Lipidology in 2014, 116 patients. The LDL baseline was 175. Patients were randomized to placebo, red yeast rice 1,200 or 2,400 for a 12-week period of time. The non-HDL cholesterol, which by the way is total minus HDL, the non-HDL cholesterol drop was 24%, and the LDL cholesterol drop from baseline was 27%, both significant relative to placebo. What was very important about the trial, using XCK, which is the name for the reduced rise, greater than 50% had reduced their LDL levels by greater than or equal to 30%, which would put the reduced rise in a moderate statin intensity category. Interestingly, at week 8, XCK was increased from 1,200 to 2,400, and they eked out another 4.6% in LDL cholesterol. So now let's talk about omega-3 fatty acids, and let me first start off with a highly prejudicial statement. The omega-3s that patients bring in, that they get in the pharmacy, are worthless. They're totally worthless. The one thing I can tell you is they're not going to cause atrial fibrillation. That is true. But other than that, they're worthless. And at the end of the talk, I have a slide that will validate that. So what are omega fatty 3 acids, omega-3 fatty acids? They come from their structure. They're called omega-3 because the first double bond is at carbon 3. Forgive me for being wonky, but the actual structure does have important impact in terms of function. So EPA, eicosapentaenoic acid, it's got 20 carbons and 5 double bonds. DHA's got 22 carbons and 6 double bonds. It turns out because of the 20 carbon length of EPA, it fits magnificently in the lipid part of membranes. Remember from biology, there's protein, lipid, protein. Well, the lipid portion is where we have single island and cholesterol. And cholesterol is well known to shoot off free radicals, and free radicals cause inflammatory pathways. So EPA is a magnificent anti-inflammatory. DHA, on the other hand, is pretty wonky. It is not good at quenching these free radicals, and as a result, it is actually atherogenic. I don't believe that we should be using EPA and DHA at all. So, having said that, where do we get these from? Well, both these omega-3s come from fish, oily fish, tuna, salmon, mackerel, and sardine. And then the other source are plants, walnuts, chia seeds, and flax seeds. Now, in order to make EPA or DHA for alpha-linoleic acid, you need to elongate it, and the elongase is not a particularly strong enzyme, so that doesn't work too terribly well. And we also need a desaturase to decrease the number of double bonds, and that doesn't work too well. So alpha-linoleic acid is an omega-3, but that said, it does not get converted in the body. You have to eat it from those various sources. So, what is the function? I already gave you some notion about EPA. EPA, because it quenches these cholesterol-driven free radicals, which promote inflammatory pathways, it is highly inflammatory. There is another substance that is called the resolvin. So when we have inflammatory processes, resolvin basically says enough, stop. And EPA promotes resolvin. So it's anti-inflammatory in that regard. And you know that 1 out of 3 patients who have atherosclerosis have a problem with inflammatory processes that's causing the problem in the first place. EPA lowers triglyceride by 19.7%. It lowers HDL by 6.3%. It lowers LDL, it raised LDL by 6.6%, and it lowered non-HDL cholesterol by 13.2%, and ApoB by about 9.7%. This is data from the REDUCE trial, which was probably one of the most magnificent trials that we've had in the last 5 years, and it was touted to be very high on the list of great trials. DHA in many studies increases LDL cholesterol. That's one reason that I think that we should not be using it. So what about that? What's the story? How did we get into the story in the first place? I've never gone fishing in my life, so I really can't tell you a whole heck of a lot about it. But basically, in the 70s, epidemiologically, we found out that SMOs in Greenland had a very low risk of myocardial infarction. And so the question was, why was that the case? And at the time, Denmark, I believe, owned Greenland. So what they did was they looked in their serum and they looked at their EPA levels and their DHA levels, and they're considerably higher than European Caucasians. And so this basically led to the notion, maybe we should be using these supplements in people that are post-divine. The first trial to come out was the GISSI trial. There were 2 forms. One was in prevention-only, in my weak Italian, and the other one was in patients that had CHL. That said, there was a 15% reduction in all-cause mortality, non-fatal MI, and stroke. Pretty impressive. So this was a positive study. Here's the problem. In 2024, we used dual platelet inhibition. In 2024, we used high-intensity statin. The first high-intensity statin, atorvastatin, came out in 1996. So this was not state-of-the-art, but in the 70s, it was certainly state-of-the-art, and this is what caught people's fancy. Now, if we go down the list, there were 5 Dutch studies that tried to emulate this. They used low doses of EPA and DHA, and they failed. They did not achieve any cardiovascular risk reduction. The VITAL trial, which is a primary prevention trial of men above 40 and women above 50, was a failure. The EPA and DHA doses were too darn low. The total was 840 milligrams of the omega-3s. The ASCEND trial was a diabetic trial. The ASCEND trial was basically diabetics without cardiovascular disease, and the total EPA and DHA dose was 840. Once again, failure. And we could go down the list, and the most recent trial, one of the most recent trials was the UMEMI trial. Now, I dare say, I put this in, these were elderly patients, ranging between 70 to 82, who had an MI, and their MI had to be 8 weeks out from randomization. The reason I'm a little leery about saying that is I'm going to be 73, and I'm not sure I want to be considered in that category of 70 to 82. But that having been said, this was, they used higher doses, 930 of EPA, 660 of DHA, with a total of 1560, and still negative trial. The strength trial was one of the most contentious trials, thanks to some of the more vociferous investigators from the Cleveland Clinic, some of whom shall remain nameless. These were 60% patients with ASCVD and 70% with diabetes. And the diabetic population, contrary to what a lot of people think, is very heterogeneous in terms of cardiovascular risk. The LDL was 75, these are all patients on statins. Trigs were 240, HDL was 36. They're on very low dose of EPA and DHA, 770 milligrams. And so basically, the secondary prevention arm, in other words, patients who had prior ASCVD, did have a numerical benefit, but it was not statistically significant, and the primary prevention was a bust. Long story short, after 39 months of bickering and arguing, the trial was ended due to futility. I will say that the form of the omega-3s could be in an ester form, or it could be in a carboxylic acid form. In the strength trial, it was in a carboxylic acid form. One of the reasons that the strength trial was different from the reducer trial is that the EPA level in the reducer trial was 135 micrograms per milliliter, which is quite high, and in the strength trial, it was 85. So there was a substantial difference in the serum levels of the EPA particularly. So, the bottom line is, what did we learn from these studies, right? What did we learn from these mistakes? Number one, that using EPA and DHA probably wasn't the best idea. And number two, we needed at least 2 grams of EPA in order to have an impact, a positive impact on cardiovascular risk reduction. So this led, the first trial was the JELIS trial. This was done in Japan. It was 18,000 patients. 9,000 were treated with EPA and statins, and 9,000 were treated with statins alone. Now, the Asians, as you probably know, are very statin sensitive. So the dose for the statins were 5 to 10 of simvastatin, which is pretty darn low, and 10 to 20 of pravastatin, which is pretty darn low. Unfortunately, the dose of EPA that they used was 1.8 grams. So that was a tremendous change from what people had done before, but it was not contrasted with a placebo. So it was open label effectively. So this is the JELIS trial, just as I've suggested. The MACE basically was the rate of MACE in the EPA group was 28%, and they had statins as well. In the statin-only group was 35%, and the reduction in MACE was 19%, which was statistically significant. In order to prove the point that this was driven by EPA, if we look at the bottom part of the slide, we see EPA/AA. So there's EPA and arachidonic acid. Arachidonic acid is a C20 compound, and it is very atherogenic. And so we look at the control group all throughout, from time 0 onward, from time 0 onward, from time 0 onward, the EPA acrobatic acid ratio was exactly the same. But look how the EPA went up dramatically from the beginning and stayed high all throughout, suggesting the mechanism driving this benefit was the uptick in EPA. And I might point out that the baseline LDL in the trial was 175 milligrams per deciliter, and the benefit of the trial was totally independent of change in LDL cholesterol. So this really kind of set the stage that maybe we got to up the ante and use higher doses of EPA, number one, and number two, avoid DHA. So this was a reduced trial. The reduced trial came out in 2018 and was touted as one of the best studies of that year. And the basic premise was that we take patients, with 8,108 patients that have history of ASCVD, 70% have ASCVD, 30% had diabetes, all on statins, and we give them EPA 2 grams BID as the treated group, and the placebo was mineral oil, and that's a very controversial issue as well, but I'll leave it on the side for the moment. The entry group were basically the patients that I just mentioned with a triglyceride level ranging between 135 and 499 milligrams per deciliter. The primary endpoint was no base composite of MI non-fatals, CVA death, hospitalization for unstable angina, and revascularization. Very interestingly, one would expect, since we're trying to lower the triglycerides, that a baseline triglyceride would be substantial in distinguishing between winners and losers. Well, as it turns out, whether the triglyceride was less than 150 or above 150, it had absolutely no bearing on the primary endpoint whatsoever. The trial was magnificently successful. The hazard ratio was 0.75 for a 25% relative risk reduction. But I found more importantly, the absolute risk reduction was 4.8%. We frequently forget about the absolute risk reduction. And so what we can do is we can basically look at the number needed to treat to prevent one event. It was 21 patients. So basically, the question then arose, why didn't the triglyceride level of 150 distinguish between winners and losers? In other words, what was the mechanism of this trial that was driving it? So let's take a sidestep for a moment. In the patients that were getting EPA, that 2 grams per day is a reasonable dose, hospitalization rate was clearly increased by 3.1%. The placebo group was down 2.1%. There was also an increase in bleeding. However, thank God there was no intracerebral bleeding as well. That gives us some inclination as what the mechanism was. These are that lower changes in the placebo. I'm just going to cut to the chase. Triglycerides dropped by 20%, HDL dropped by 6.3%, LDL went up by 6.6%, and non-HDL by 13.1%. ApoB is really important. ApoB is a marker for atherogenic particles. So for every one particle that's atherogenic, we have one ApoB. So it gives us a very good assessment for particle number. And you don't have to fast for that, by the way. And it's used very often. Notice that in the HSCRP, the placebo group was off the wall. It went up about 35%, and the reduction by EPA was 39.5%. This led to a tremendous argument that this is not an EPA study, this is not an omega-3 study. This is the study of mineral oil being inflammatory and causing problems. And quite honestly, I think that that's a bunch of hooey. I do not buy that. And if we want, we can talk about that. I have a slide to prove the point. So the question that arose was, if we got these very favorable events through modest triglyceride lowering, what was the mechanism? How did this happen? And this led to a trial called the Evaporate trial. The Evaporate trial was, the limits were pretty much the same. It was EPA 2 grams twice a day versus placebo. The placebo was mineral oil. The only difference was the Evaporate trial was predicated on doing a baseline CT angiogram at the initiation of the trial, and then a follow-up CT angiogram 18 weeks later. Now, I don't know if most of you are aware, but the plaques that are going to do you in on a heart attack or a stroke are not the plaques that are 85%, that are that have a fibrous cap and that have structural integrity. These are plaques that are less than 30%, and they're gushy. And if you've ever had a steak and you eat the grizzle, that's what the black is like. So they were questioning what the impact of EPA was on various types of black, and in their parlance, it was called low attenuation black or vulnerable black. Typically, those are 30 to 40%. So here we look at, I guess we might have a white or red. The blue represents the placebo, and the red represents IBE, which was the intervention. IBE is icosapentalenol level, that's the trade name, but it's EPA. And you can see it's a gigantic increase in the low attenuation black of 110%, whereas the EPA lowered the vulnerable black by 17%. Fibrofatty black has a little more integrity, but still has a great probability of rupturing, and that was a 34% reduction versus 32%. So the bottom line was the evaporate trial said, here's where the money was. In fact, triglycerides were identifying a group of people that were highly atherogenic with a fair amount of low attenuated plaque that were vulnerable, and those are the people that had benefit. And triglycerides were a mark over that. So if we take this, a step further, and we want to know what EPA did, it did three things. If you fix like that, would be wonderful. It produced ApoB-containing with the proteins by 9.7%. Number one, it clearly had an anti-platelet effect, and we know that what happens when plaque ruptures, the plaque basically stimulates platelet aggregation. Platelet aggregation then goes in a second phase, in the second raid, and that causes an event either in the brain or in the heart or in the legs. And we know that the hsCRP dropped pretty substantially, although the Cleveland Clinic crowd was still saying this is a mineral oil effect. Let's see. Okay, so rather than go back and forth, the investigators, and that blew off as well this morning as the comment was to basically say, let's take a placebo, the mineral oil placebo, on one hand, and let's take the placebo from the Garlic 5 trial. The Garlic 5 trial was 8 diabetics whose entry criteria were a calcium score of greater than 20. The interesting point was the placebo in the Garlic 5 was crystalline cellulose, something on tip of everybody's tongue. Crystalline cellulose is absolutely inert. So if there was a difference between these two placebos, and what they did was they plotted it on the x-axis, that's their baseline, and they plotted on the y-axis. And they did a regression line. And the red represents the evaporate numbers data, and the blue the garlic. Well, the line is a straight line, as good as you can see, and this was adjusted for age, triglyceride level, etc. And basically, this line shows there is literally no difference in the placebo change from baseline to 8 months later in the two trials, negating the notion that this was a problem of mineral oil and the EPA did nothing, and that was probably the straw that closed the Cleveland Clinic's gripes about the trial. So I think that's an important point worth making because you'll hear people argue about that. So let's change channels. Let's talk about garlic. Garlic comes in various formats. Garlic powder, 600 to 5,600 milligrams a day. Garlic oil, 90 to 18 milligrams a day. Aged garlic is 1,000 to 7,200 milligrams a day. And raw garlic, 4 to 10 grams. So garlic's active ingredient is called allicin, A-L-L-I-C-I-N. I really don't think it does a whole heck of a lot. It's supposed to inhibit HMG-CoA reductase, which would lower LDL cholesterol. So this is a meta-analysis, and I can't, you also have to be careful, but with meta-analysis, it's like having one great study and then basically impact on the results of all the other studies. The baseline LDL is 130, and yet the mean LDL with garlic, I believe they used the garlic oil in this trial, dropped by 2 to 11%. Nothing to write home about. So from my perspective, garlic does not have a substantial impact on LDL cholesterol and had no effect on HDL and triglycerides. One thing one has to be aware of, that garlic does have an effect on bleeding. And so if a patient is consuming large amounts of garlic prior to a surgical event, that really needs to be put into the chart because significant bleeding can result as a result of the garlic. And I'm not sure what the mechanism, but it clearly interferes with the coagulation cascade. As I said before, there are very few trials that have ASCVD patient population. The omega-3s and brain-used rice and garlic was clearly not an exception. So what about plant sterols? We had a very erudite talk from a professor from Harvard. Basically, the way plant sterols work is they compete with cholesterol for cholesterol absorption. This absorption is either from the bile into the enterocyte or into the hepatocyte, or it is absorption from the lumen of the gut into the enterocyte. Probably the best way to see this, I'm going to try and use sensitivity. This is the bile, and you see green is plant sterol, cholesterol is brown. The Niemann-Pick C1L1 transporter basically causes absorption of cholesterol and plant sterol. The same thing is true with the small bowel movement. They both are back in. However, the way we're constructed is such that if suppose you absorb too much plant sterol, the way we get rid of that is through ABCG5 and ABCG8. That stands for 18 PAs binding is at 5 and 8. Asians are much more prone to this syndrome is called hyposphosphatemia. The pump does not work. Basically, the plant sterols are absorbed promiscuously, and they cause plaque just as if it were cholesterol. And you need to know that. You're not going to know that from the history because these are autosomal recessive diseases, and it's going to be hard to get that. But if someone has a history of premature ASCVD, I suggest that you send blood to Ernie Schaefer, friend of mine, to check the pharmacokinetics versus levels, and they'll be all the charts. And certainly you don't want to give these patients plant sterols because it's just going to make a bad situation worse, and that does happen. Okay, so that's basically where we are. Now let me change channels. So we're going to want to talk about diabetes, so I'll throw my hat into the fray. This is a trial that kind of struck my fancy. It's a cinnamon trial, and it's looking at the effect of cinnamon on glycemic control. So let me just tell you that if you look at the cinnamon studies, and I haven't gone through everyone, but they're very varying results on glycemia. First of all, the cinnamon doses were between 0.5 and 6 grams, which is pretty substantial variance. Number two, the study duration were 4 to 12 weeks. And number three, the trials were very small numbers. So it's unclear. And by the way, there's at least 11 or 15 different types of cinnamon. So basically what I liked about this trial and thought it was reasonable to present was number one, it's a crossover trial. And I think crossover trials are excellent because you are basically your own placebo, your own control. You go to one station, and in this case cinnamon, cross over to placebo. If you start placebo, cross over to cinnamon. So it's a good way of looking at internal, sort of internal control. This study was 18 patients. These patients had either IGT or obese, and the BMIs were about 31 on average. And so the trial was 12 weeks. There were 2 interventions. You either got cinnamon or placebo, and the cinnamon dose was 4 grams, and the placebo was the same capsule, so it looked once a week, so they didn't know what they were getting. And then there was a washout, and then the second intervention took place. So if you got cinnamon in the first intervention and you crossed over to get placebo, if you got placebo in the first intervention, you'd cross over to get the cinnamon. At time 0, 4, 6, and 10, they did oral glucose tolerance tests, and those oral glucose tolerance tests were done for 180 minutes. They also took stool specimens. I know there was some discussion about microbiome. Well, this gets into things as well. So the question was, did 4 grams of cinnamon have any benefit? And most importantly, they used CGMS. And that's how they were able to construct the glycemic results of cinnamon versus placebo. I think they used, I'm pretty sure they used the Pre-Spa Libre, but I honestly don't remember which version it was. So basically that was a trial. And there is the time. They basically did the glucose tolerance test. Time 4 the same, time 6 the same, and up to the beginning of the washout, and time 10. And specifically, they looked at the effect of the oral glucose tolerance just on glucagon, on triglyceride, and on glucose-dependent insulin-tropic polypeptide concentration, which I believe we heard about previously. So this is the printout, 24-hour printout. The dots represent the placebo, The cinnamon represents the solid ions. And basically, I think you just eyeball them, you can see there's a difference between those two curves. And so when this was studied a little more aggressively, the glucose concentrations over a 24-hour period were consistently and significantly lower with cinnamon, 4 grams. The p-value is there. But to make it a little more scientific, they did this quantitatively, so they did the net area under the curve, recognizing that some of those numbers were below the x-axis, and they subtracted those out. And still, there was a significant reduction in the glycemic area under the curve in 24 hours. And then finally, they looked at the peaks. So what I didn't say is the way they generated these curves is they basically took 4 readings where they took in an hour, where they took the median value in that particular time period and then multiplied that ultimately, so they got 96 readings per day. So it was basically 4 in an hour, and then 24 hours was basically 96 readings per day in the various groups. And when they did that also for the glucose peaks, they picked a period of time, let's say an interval of 15 minutes, because it was 4 in an hour, and they measured that point to the peak and what was the distance. And if that distance was significant, then obviously the peaks were lower as a result of this intervention, and there's a p-value. So that was the one part of the trial that basically used CGMS, and I don't believe there's a lot of trials with cinnamon using CGMS. So the second thing is they looked at the various hormones when they did the glucose tolerance. Glucose-dependent insulinotropic polypeptide was measured and dropped and went up significantly compared to placebo. So that was an interesting point. Glucagon levels went down compared to placebo, and that was significant. And triglycerides, again, these were 180-minute oral glucose tolerance tests decreased with cinnamon, and that was compared to placebo. I will point out that one of the pretty benefits of glucose-dependent insulinotropic polypeptide is it stabilizes lipoprotein lipase, which is one of the most significant enzymes for triglyceride catabolism and could play a role in why the triglyceride levels went down significantly. So the bottom line is, one point I do want to make, when you do these kinds of studies, there's all kinds of confounders that you really have to control for. So when they're generating the regression line, they adjust it for age, sex, A1C at baseline, fasting blood sugar baseline, and systolic and diastolic pressure. And in none of these potential confounders biased the results. They were basically legit. The statistics held out quite well. Finally, and I'm certainly not an expert on this, they did stool specimens. So they were checking the microbiome. Pterosporobacter and dialyster were reduced with cinnamon. What does that mean? Please don't ask me, but I'll read the next line. In IgD patients, there was a paper from Varigals and PLOS ONE that dialyster has shown a positive correlation between this bacterium and A1C. So putative mechanism, I'm not saying this is what generated it, but the putative mechanism could have been in part related to change in the microbiome. And we know more and more that's playing a role in a lot of metabolic disorders. So it's always nice to have a hypothesis. One thing I did not mention during the trial, all patients were on a low polyphenol diet because cinnamon has polyphenol, and they didn't want to confound the results from the cinnamon based upon the fact that people were eating whatever they wanted. So what was the putative mechanism for why there was benefit? Well, the cinnamon contains a high polyphenol content, and I believe the other speaker had spoken about that. Polyphenols can improve insulin sensitivity. They cause phosphorylation by tyrosine kinase of the insulin receptor, and as a result of that activation, there is a series of events that occur, specifically glucose vesicles go from the cytoplasm, translocate to the membrane, and then transport like a shuttle sugar into the cell. And so that's one potentially benefit. There was also an anti-inflammatory effect. I'm not saying this is what caused the cinnamon to be beneficial, but it certainly is a reasonable hypothesis. So, having said that, my take is the cinnamon story is certainly interesting. It's alive, and it's one of the first trials to use 4 grams daily with CGMS. So we can take that for its worth. So One of the things I remember when Actos came out and the FDA came out, everybody said, oh, no, we can't tell which is better. We got to do a head-to-head trial, head-to-head trial, head-to-head trial. So this is the sports trial. It is a head-to-head trial. The sports trial asked a very simple question. Since the topic of this conversation is supplements, the question is, what happens if we take 6 supplements and contrast that with rosuvastatin 5 milligrams? Will there be a benefit? Will there be not a benefit? So the only way to do that is to do is learning, and that's exactly what they did. So basically, they took individuals, and these, it's a little wonky, but these patients had pool core equation study, 10-year risks up to 10.3%, which puts them into an intermediate risk category. They did not have ASCVD. Their LDLs were 70 to 189, and so the design of the trial was to basically give them rosuvastatin 5, and this was parallel. So basically, if you're on rosuvastatin 5, you stayed on rosuvastatin 5. The next would be a placebo. The next would be a supplement in a pre-specified order. The reason for doing the pre-specified order is because when we're doing 6 or 7 comparisons, you need extremely low p-value to see significance between one group and the other, and that's why they do that. So in any event, so that was the trial. The primary endpoint, and by the way, each of the groups had 25 patients in them, so there was a total of 190 patients. The primary endpoint was after 28 weeks was a reduction in LDL cholesterol relative to baseline, and that was contrasted with rosuvastatin 5 and placebo. The secondary objective was percentage degree after 28 weeks for HDL, total cholesterol, triglycerides, and anti-inflammatory markers, HSCRP. And the results, I just wanted to go all together. The LDL cholesterol reduction with rosuvastatin was greater than all supplements. It was greater than placebo, and there was not a single supplement that had any benefit that overtook or would be more significant than rosuvastatin. The LDL cholesterol drop was significant with this p-value of 0.001. The second take-home point was no dietary supplement brought about a significant drop in LDL compared to placebo. So take home, from my perspective, in patients with intermediate 10-year risk, this was 7.3% to about 10.2%, for ASCVD for full core equation risk scores, 6 supplements failed to lower baseline LDL significantly versus placebo, whereas rosuvastatin 5 milligrams daily reduced baseline LDL in a statistically significant manner. My money, this would imply that there is absolutely no benefit in using supplements in addition to rosuvastatin in this patient population. Whether it would be true for others, that needs to be, that is certainly the point of that can be argued. These are the various things that they use: fish oil, cinnamon, garlic. These are commonly used supplements, and so that's why I put it up, because this is what you'll see the patient come in with. Interestingly, for cinnamon, they use 2,400 milligrams, and recall in the trial that I mentioned in the cinnamon trial, it was 4 grams, so it was 4,000 milligrams. But that said, basically none of these were successful. So, what I like about this is the pictures were 1,000 words, so basically LDL cholesterol, we receive 5, dropped by 38%, and there's not a single one of the other supplements that came close to this. When we looked at rosuvastatin relative to placebo, it was statistically significant. I have a laser pointer that's one up to the left part of the slides. The p-value is significant. Fish oil, significant. Cinnamon, fish oil, cinnamon, significant. Garlic, significant. Turmeric, significant. And plain steer oil, significant. And reduced rice, significant. So not any one of these supplements had any benefit that basically was greater than or even equal to rosuvastatin. Interestingly, I showed you that garlic, in the meta-analysis, the LDL cholesterol went up, but went up, and this is off. I don't run things the same type of garlic in this study, in this supplement compared to the meta-analysis. I'm always worried about the meta-analysis, but that's a totally different story. So that was the first point. The second point is from change in HSCRP. So rosuvastatin is a moderately intense statin at 5 milligrams. You would expect a 10% reduction in HSCRP. It was only 5%. That could be because the study groups were small. Each group had 25 patients, but it also could be true that the dose of rosuvastatin at 5 milligrams would have, the HSCRP reductions are dose dependent. And so why cinnamon went up in HSCRP, I think that's just the vagaries of having 25 people in a group. I think this is statistical anomaly. HDL dropped by 2.3%. The plant sterols are not surprising that dropped by 4%, and the reason why, how the plant sterols work, they compete with cholesterol absorption, so there's less cholesterol absorption, the cholesterol pool goes down, and there's less cholesterol to be distributed into an HDL particle. So that's not surprising at all. So basically, that's that. And this is the total cholesterol. So the total cholesterol is not unusual for it to drop 2/3 of what the low cholesterol drop, and this is a 24% drop. And basically no significant differences when you do comparisons between all the various supplements. In terms of the change in triglycerides, a 90% reduction in rosuvastatin was, I would have thought it would not have been as high. Typically, triglycerides would drop about 20 to 25%, but nonetheless, it was significant, and none of the other supplements did anything. So, this is my, I'm not into regulation. I didn't go to law school, and I'm not a big government person. Having established that, I just want to quote 2 papers, and then I'll be finished. The New Zealand study looked at 32 fish oil supplements on the market. Now, in New Zealand, like in the United States, it is the mandate of a company to say, this is the amount of supplement we're putting in this bottle. Okay, only 3 of the 32 fish oil supplements had an EPA and DHA content equal to or higher than the labeled content. Meaning, in plain English, 29 of them were grossly and egregiously overestimated. Okay, so that's one point. The second point is batch-to-batch variability is a real problem with supplements because no one's checking it. So that's the second problem. And now let's return to the US of A. This is from one of my favorite investigators from Harvard, R. Preston Mason, PhD. So he looked at the 3 best-selling fish oil dietary supplements in the US of A. And these supplements should have had EPA and DHA. And guess what he found? 30 different fatty acids in that bottle that should never have been there. So none of this is being controlled. The FDA is not in quality control. So I am very leery about supplements. Just to remind you that when you're taking 1 gram of omega-3 EPA DHA, you get no benefit whatsoever, number 1, and number 2, you won't get anything. So from my perspective, I'm not sure when it comes to supplements, anyone has your back. I think I promised somebody that this would be a 30-minute talk, and if I'm close to 30 minutes, then I'll take the bronze medal. Any questions?